Yeah. So my talk is going to be about special considerations in atrial fibrillation in women. The outline of my talk, we're going to have a quick introduction, important general concepts when we're dealing with atrial fibrillation that I thought it doesn't matter whether you're dealing with a male or a female. You should have at least a clue about these important things. The special considerations in women, including risk factors, pathophysiology, prognosis, and the gaps that we're actually facing in management. Unfortunately, especially the gap section, it's mainly focused in the United States. I haven't found real data about the region that we're in. So this is something I think is going to need further and more research, inshallah, in the future. Rate versus rhythm control, the evidence, is it different between men and women? The available strategies if you're choosing a rhythm control strategy, and a quick conclusion. So as we all know, atrial fibrillation is a supraventricular tachycardia that's characterized by uncoordinated atrial activation that leads to atrial remodeling. And we'll talk later on about the stages of the atrial remodeling. It's the most common sustained cardiac arrhythmia disturbance in adults. The hemodynamics impairment and the thromboembolic events related to atrial fibrillation result in significant morbidity, mortality, and of course a huge cost in the healthcare sector. So what are the important concepts that I think everybody dealing with atrial fibrillation should have? One is the complexity of atrial fibrillation. When you see a slide that this complex when it comes to pathophysiology or risk factors for a disease, you should always know that this disease is super complex and very difficult to control. So whenever you're dealing with atrial fibrillation, please keep in mind that you're not dealing with a simple disease, and you need to correct all the risk factors that has led this patient to develop atrial fibrillation. So if you have a patient who has, let's say, hypertension, you need to make sure that his hypertension is well controlled. Diabetes, the same, it should be well controlled. Before I start committing this patient to a rhythm or a rate control strategy. So you should always make sure that the risk factors are well controlled because they have a significant impact, even in the results, let's say, for ablation. It has been studied that whenever you have uncontrolled risk factors, the results of your procedure are going to be bad. So I just wanted to highlight the fact that more and more even teams, when you go to US or you go to Europe, they're dealing with atrial fibrillation in a multidisciplinary clinic. They don't treat it on a single aspect. Like you will have an internist, a nurse, a cardiologist, and even a psychiatrist actually sitting in that clinic. So it's a very complex and multifactorial disease. We need to control it. Atrial remodeling, as we said, it has 3 stages. The electrical stage, that the first stage, happens within hours. And it's mainly due to the shortening of the refractory periods in the atria. So the shorter your refractory period, the more likely for the tissue to be excited. So this leads to sustaining the arrhythmia. And it happens very quickly. It's because of the derangement in the sodium and the calcium channels. This happens very quickly within hours. So most of the time, this will stop spontaneously and the patient will cardiovert. But if the patient is heading towards the persistent stage, he's going to start developing what we call the contractile remodeling. It happens normally within days. And this is a complete loss of the contraction function or the reduced atrial contractility. This is mainly led by the loss or the derangement of the intracellular calcium. Because if you remember the action potential, the plateau phase is led by the calcium channels. And once you start having derangement in this, your plateau phase shortens and the contraction force of the contractility of the muscle itself goes down. So this sets the stage for the thrombus formation. And then if the patient continues to be in atrial fibrillation, he starts developing what we call the structural remodeling. And this is mainly the enlargement of the left atrium itself and the left atrial appendage. Interesting enough, we'll discuss it a little bit later on, that this is mainly led by the atrial fibrosis. And I thought, honestly, initially it was only the electrical and the contractile remodeling, but I think in females there is something else also coming into play. We'll discuss it inshallah later. The third important concept is the progression from paroxysmal to persistent atrial fibrillation. So during the work of Michel Hesseguer in France, we all knew that the atrial fibrillation, or the origin of the atrial fibrillation, or the trigger from atrial fibrillation, is mainly located in the pulmonary veins. This holds true when you're dealing with paroxysmal atrial fibrillation. So in the early stages, you're actually dealing with a trigger-based disease. Then you start facing more functional re-entry substrate. This happens during the electrical remodeling phase. You have some tissues that are, have reached their refractory period, the others are, can be excited. So this creates functional re-entry substrate. But when the patient stays for a later stages, it reaches the structural re-entry substrate, and this normally leads to the atrial fibrosis and difficulty in controlling the disease. And normally when you reach the structural re-entry substrate, you're dealing with persistent or long-standing persistent atrial fibrillation, or even the chronic stages of atrial fibrillation, where you lost hope to control or to achieve rhythm control in this patient. So it's very important actually to deal with this patient early. So what are the special considerations in female? First, the risk factors. Of course, we all know that age in atrial fibrillation is the most important risk factor. The older you are, the more likely for you to develop atrial fibrillation. Each 10 years almost, they double the risk of developing atrial fibrillation. So women in general, they're on average older than men at the age of first diagnosis of atrial fibrillation. And if we correct for age, the incidence of atrial fibrillation is actually higher in males compared to female. However, if we look at the absolute number, because females live longer, the absolute number between male and female is almost the same. When we talk about genetics, there is a potassium channel gene, and that's X-linked gene. Some studies suggested that because female have two X chromosome, and this gene actually reduces or protects you from atrial fibrillation, they're less likely to develop atrial fibrillation. What was even more interesting is that when they found that this, some families that have atrial fibrillation, they found that there is a deletion in the KCNE5 gene, leading for them having more atrial fibrillation. So genetics, they do play a factor, and the double X chromosome that the females have is actually a protective measure for them. So hypertension and valvular disease, women with atrial fibrillation have normally a higher prevalence of hypertension and higher prevalence of valvular heart disease compared to male with atrial fibrillation. Again, this is, goes back to my initial slide where I said a complex disease, and it needs attention on multiple things. I think in females we should be very aggressive with hypertension, and we try to control their valvular heart disease at the early stages. So this was a very interesting paper they came across. They studied more than 230, it's an observational study, 230,000 females were followed for 12 years. And then they started looking into the, what were the leading causes or the risk factors for developing atrial fibrillation. So the interesting thing that I think cardiologists never ask about, they found that irregular menstrual cycles, they actually result, or they are a risk, there is a risk factor for atrial fibrillation. Null parity, especially when it's not a choice, when it's actually a disease, or there is something hidden in the background. When it's a choice, it wasn't really a risk factor. When it was a part of a disease, it was actually a risk factor for developing atrial fibrillation. And grand multiparity, they found that females who had more than 7 kids, they had a higher chance of developing atrial fibrillation. So I think more and more we should be talking with females about their cycles, which we, honestly, myself, I never did before. So when we talk about the pathophysiology, there are structural differences and electrical differences between males and females. In general, females, they have a reduced ventricular mass and a reduced or smaller atria and ventricle compared to female, and this is a protective thing. So we think this might actually lead to the lower incidence of atrial fibrillation in females. Having said that, a study was done. It wasn't like a large study. I think it was only 160 females. Underwent MRIs, and they had the protocol. It's a study that was done in Utah. They had the protocol to measure the fibrosis in the atria, and they found, in general, whether they have actually atrial fibrillation or no, females are more likely to have atrial fibrosis. So there was another study that was done to see why they have higher incidence of atrial fibrosis. And in general, females, they have a higher concentration compared to males of C-reactive protein, and they have higher plasma concentration of fibroblast growth factor 23. Both of these, they were associated with an increased risk of atrial fibrillation and might contribute to the increased atrial fibrosis in female. So for me, I think as an electrophysiologist, I think based on this fact, I would understand why a female would have a tendency to have a more resistant disease compared to male. Because most probably when they presented, they already have some sort of atrial fibrosis. But these are speculations. This is my own interpretation to the data. Again, they have electrical differences, the female. So in rabbit models, the left atrial and pulmonary vein tissue from females displayed longer action potential durations. And in females during ablation studies, the females actually in the pulmonary vein, they have a more negative resting membrane potential. So this makes it less likely for the females to develop atrial fibrillation. Again, the incidence in females is less compared to males. Hormones, which was a very interesting fact for me. So progesterone actually shortens the action potential duration and shortens the QT. And estradiol, on the other hand, prolongs the cardiac conduction. Like there was a study that studied the in rabbits again, and injecting estradiol actually resulted in prolonging the right intra and atrial and atrioventricular nodal conduction times, and the right atrial effective refractory period was prolonged just by injection estradiol. So you would think that actually the menstrual cycle for a female will actually play a huge role in the likelihood of developing the arrhythmia. So I would guess that the follicular phase will have less attacks, and the luteal phase, because of higher progesterone, will have more attacks of atrial fibrillation. Again, a speculation yet to be proven. Clinical presentation, symptoms. So females are less likely to have asymptomatic atrial fibrillation. So most of the time, females will have symptoms, and they will have a tendency to have a higher ventricular rate compared to male. They are more likely to have a longer duration of symptoms. Like most of the time, females will present late. And it's based on the fact they have more likelihood of having atypical symptoms. So a lot of the time, females, they will present with weakness and fatigue, and less likely to present with palpitation compared to males who have atrial fibrillation. Females have a worse quality of life, and that was shown in multiple studies, and they have more frequent depressions when they develop atrial fibrillation. So prognosis, stroke. Females, they have a higher risk of stroke compared to male, and I think this has been shown because it was one of the factors that was added to the CHAS-VASc. Again, here, one theory, even though the evidence behind it is weak, but they are saying that the fibroblast growth factor was actually associated with a higher risk of cardioembolic stroke and not the other sort of stroke. So maybe this is something that needs further investigation. Heart failure. Most of the studies have shown no difference between heart failure in males and females. Very recent study has shown they might actually be in a higher risk for developing heart failure or preserved ejection fraction. Like females who had atrial fibrillation, they were more likely to develop this disease compared to males. Dementia showed no difference between males and females. And mortality, it has been shown that females have a higher mortality when they develop atrial fibrillation compared to males when you correct to other risk factors. So this slide summarizes basically what we discussed. The prevalence, they have a lower incidence, a lower prevalence. The pathophysiology presentation and prognosis we talked about in details, as well as the risk factors and genetics. So rhythm control, is it the right choice in women? So I think one of the most important trials that was recently published is the eSafeNet, and it showed actually an improved or a reduction in mortality when you go for a rhythm control strategy. This was different from the result from the AFFIRM trial. So the interesting point is that females were around 50% of the population of this study. So you would speculate that the benefit would actually apply for both males and females, that rhythm control is actually superior to rate control. However, unfortunately, at least in the US, females are more committed to rate control strategies compared to male patients. So what are the strategies available if I wanted to go for rhythm control? Of course, medications and catheter ablation. Of course, more advanced surgical techniques and hybrid techniques are there. But I think by now, the evidence has been accumulating over the years that regardless of the mechanism or technology that you use for atrial fibrillation ablation will always be superior to medications. Even the AFFIRM trial, the arm that had the rhythm control strategy and went for medical therapy, only 40% of them, they remained in sinus rhythm, despite using amiodarone and all the other medications. So if you want to go for a rhythm control strategy, please think about ablation. So we all knew about the Cabana trial, and Cabana confirmed what we just discussed. And females were represented of almost 40% of this population. So when you go for a rhythm control strategy, what has been shown to be a superior to rate control strategy, catheter ablation is superior. And this has impacted the guidelines already. When we see the guidelines, catheter ablation is actually gaining more and more when you think about rhythm control strategy. And this is a very interesting slide, and I think it's actually a cardinal slide. These patients, they do best when they are referred early. And honestly, based on the fact that we just discussed that females are more likely to have atrial fibrosis, I think it plays even a more important role, like an early referral. And considering, I think, atrial fibrillation ablation in females, it's a very, very important thing. So the Intermountain Health Study, they have 4,500 patients, and they group them. They all went for atrial fibrillation ablation, but the cases where the referral was early, they did better, even on the long term. And in this study, females represented around 40%. So what are the challenges and the gaps in management? Of course, this is based in US. As I mentioned earlier, there's not a lot of data about this outside US and Europe. So we know for a fact that females have a higher chance of developing stroke. But at least in US, they have less prescriptions for NOACs. So it actually was contradictory, because the data is saying if a female is on warfarin, she's more likely to develop stroke compared to male, but they were prescribed less NOACs in US. So that was a very interesting finding. I think here we're a little bit more generous than the United States. I think we put females in preference on NOACs. So, sorry. Yeah, I have like a couple of slides to go. Sorry, back. So yeah, as I was saying, the NOACs protect them more than the antivitamin K. As I mentioned earlier, females are more likely to go for a rate control strategy, and they're more likely to be described the cardiac glycoside, which has been associated with an increased risk of breast cancer and mortality. So I think we need to shift this to a more rhythm control strategy rather than rate control strategy. They're less likely to be referred for atrial fibrillation ablation, and that's again in the US. I think here we have a tendency to treat both equally. So I think from my research is that we need to be a little bit more aggressive when we're treating with atrial fibrillation females. So my conclusion, women generally have a lower age-adjusted incidence and prevalence of atrial fibrillation than men. But as I mentioned, if you look at the absolute number, it's almost the same because females have a tendency to live longer. Women are likely to present with atypical symptoms, which might delay the diagnosis and might set the stage for the atrial fibrosis to kick in. So the earlier and the more rigorously we screen females, the more likely for us to detect them early and to treat them early and commit them for a rhythm control strategy. Female sex have been shown to be a risk factor for atrial fibrillation-related stroke and mortality. Women are less likely to undergo rhythm control strategy compared to men, at least in the United States. And further research is needed to address the knowledge gaps and sex differences in atrial fibrillation. Thank you very much.